Thank you so much, Kate, for the introduction. Good afternoon, everyone. I'm glad to be here. Thank you, Genomenon Mastermind, for the invitation to speak today. So, like Kate kind of introduced, I'm a director for the Molecular Diagnostics Lab at Lurie Children's. We do genetic testing for pediatric patients who either have a germline disorder or a malignancy. So today I'm going to be sharing some work that we have done with our patients and also how we've kind of used Mastermind in our work. So just to start off, because with a pediatric patient, when we are examining genetic conditions, they all qualify as a rare disease. But what exactly do we mean when we say a rare disease? A rare disease is really a disorder that affects less than 200,000 people in the US. So overall incidence, you would think about as, less than 1 in 1,600. So overall, there's by definition about 7,000 known rare disease in the world right now that we know of. About 80% of them have a genetic etiology. So by definition, a lot of the pediatric conditions all fall under this rare bucket. For example, childhood cancers, a lot of the germline conditions, they're all rare. But it really is a spectrum of rare. I'm going to be telling you some cases that are kind of ultra rare, that are even rarer than the definition of a rare disease. But overall, we know that, I think, as attendees to ASHG, that, really this NGS-based testing for pediatric patients, this pediatric germline conditions or malignancies has really kind of exploded over time. This large growth is driven by our ability to use whole exome sequencing and whole genome sequencing for diagnosing these patients. So really the main difference is, as we know, exome is focusing on coding regions and whole genome sequencing on really all regions of the genome. So as part of our Lurie Children's Hospital, we are part of the NORD Rare Disease Center of Excellence, and we just recently became a UDN clinical site, which is an undiagnosed disease network. So part of the things I'm going to be talking about today is really kind of the underpinnings of how we became part of this association. But the overall goal is really to be a center for diagnosing rare disease, all rare disease, whether they're genetic or not. But really, as part of the genetics lab at Lurie, our focus is really trying to answer the questions for rare genetic conditions and really try to improve the care of these patients with rare disease. And so at Lurie, we have a team of our clinical genetics team, who's made up of our geneticists and our genetic counselors, the clinical lab who does the testing, and we have a research lab that can kind of collaborate and come up with this rare consortium, which is really a team of people looking at how we can generate a diagnosis for these patients with rare conditions. And one of the projects that was undertaken, starting from, I would say, 2020, 2021, was this precision medicine push to kind of really answer the question of can we use our genetic infrastructure to try to diagnose some of these undiagnosed patients. And a lot of the patients that come to Lurie for care, they do get, on a basic level, whole exome sequencing at the standard reference lab, but there's still a good number that remain undiagnosed. So we kept this project that started in 2020, 2021, that wanted to answer the question of, if we use whole genome sequencing, because at that time, right now, whole genome sequencing is really becoming the center of care for a lot of these patients with rare disease. But in 2020, 2021, it was still really whole exome sequencing. So we were trying to see if we could use whole genome sequencing for patients whom had remained undiagnosed after panel testing, whole exome testing, to see what is the diagnostic increase in diagnostic yield from whole genome sequencing that we could achieve. At the same time, we were undergoing this build-up of infrastructure because really we started from scratch, right? So being able to build a genomic diagnostics lab, to have the infrastructure in terms of having the computational capacity to analyze the whole genome data set, to have a system that can let us handle this huge data set analysis was something that we had to all put together. So I'm going to describe to you some of these things that kind of came into place and how we have kind of formulated our pipeline for analyses. So in this study, when we started enrolling, essentially we looked at pediatric patients that have a very complex medical history that suggests that they could have a Mendelian single gene disorder, but their previous genetic testing results are inconclusive or negative. And at the same time, they need to have parents who would be willing to also participate and contribute their sample, meaning their biological mother and father, because that does increase the yield for whole genome testing. And again, they sign an informed research consent, and we enroll the whole family as a study, as a trio. So in the initial goal, we had a overall goal of enrolling 20 trios, which we completed in 2022, and right now we are in the second phase. We're enrolling another 20. So our study workflow was to really look at enrolling the patients, performing whole genome sequencing in the lab that we had sent out to, at that time, to our partner institutions. And at the same time, we would reanalyze the whole exome data that was previously generated by a reference lab. So whole exome sequencing was previously done by a reference lab, and they were non-diagnostic. So we would request the data to be returned in-house. And on the infrastructure that was built at Lurie, we completed the bioinformatics analyses on the Dragon pipeline in our AWS environment. We went with a cloud environment because, just so that we don't have to maintain a physical computing infrastructure. And then we completed our tertiary analysis in Fabric. So obviously for whole genome sequencing, there is a huge number of variants that get detected in just one single patient. When you do a whole genome, you're looking at 5 million variants. How do you get down to as little variants that you think are clinically relevant? So I'm going to kind of skip to the end point of the study because it's really so many different components of the study that I really want to, that we can talk about, but really I want to look at focus on the results today. So when we examined this whole genome sequencing study that we had completed for these 20 families who were previously undiagnosed from a reference lab, whole exome sequencing, we actually found that from our 20, we had 4 cases that were diagnostic from whole genome and 2 that were candidates. But kind of going through, we were kind of surprised, right? Like, this were undiagnosed exome. Now, how do we manage to find something? And kind of really looking at what were the reasons why they were undiagnosed by exome and how come genome managed to kind of answer that question, right? Or did actually genome contribute any component to that whole equation of finding answers for these patients? Because I do believe that if you examine the fail points of how things had occurred, you'll be able to improve your own process to see, even though it wasn't our process, right? But kind of examining what could have happened to kind of really improve the analytical pipeline for whole exome, whole genome sequencing. So I started with a story, one of the cases of Zach. I'm going to name him Zach. He was a 13-year-old boy of Pakistani descent. He had a very strong family history of consanguinity. His parents, grandparents were first cousins. And we found that he had a pathogenic homozygous variant in ChRNA3. So this genetic finding is right now diagnostic for autosomal recessive familial autonomic ganglionopathy. So when we look at his condition is really what I call the ultra rare. It's not just rare with like 1 in less than 1,600. This is like he's the 9th person in the world who is known to have this disease. In 2019, there were 5 patients from 3 families that were published with ChRNA3 disease-causing variants, either compound heterozygous or homozygous. So this patient is really the 9th person. And so he's a really ultra-rare condition that we discovered from our study, but kind of really looking at what exactly happened in his diagnostic journey, right? Because he's 13 years old. When he was born, he had a lot of medical issues. So he was born in 2007, and in 2008, he had a lot of medical issues. He had his intestinal, his gut taken out. He had a surgery. He had a bowel resection. He had very poor weight gain, aortic root dilation, very recurrent infections. So they kind of went on for many years, more than 10 years. So in 2019 was when the first paper that described ChRNA3 disease-causing variants was published. He received in 2020 a whole exome sequencing at a reference lab that was non-diagnostic, right? So what happened between 2019 and 2020 that you would think that in 2020 when the exome was performed, that the 2019 paper would be reviewed, and his diagnosis would be known since 2020. But it was in late 2020 that when we enrolled him in the study, and when we reanalyzed his whole exome sequencing results and gave him a genome, that we discovered that, oh, there's this paper in 2019 that was published about chRNA3. So he had a period of, not too long, about a year, that he could have been diagnosed, but it was missed, right? Without the study, he might have gotten a reanalysis 2 years down the road, but it's really this period of undiagnosed that if we could avoid would be great. So how do we avoid this misdiagnosis in the testing lab? And as part of a clinical diagnostic lab, this is things that we kind of examine, right? We always want to kind of go back to the root cause of how these things could have happened in the reference lab, and then maybe improve our own pipeline such that, this kind of things would be minimized. So that was the first case. And then again, a second case, sort of this very similar story. DHX16, this other case, 16-year-old female, born in 2004, very complex medical presentation. Went undiagnosed for many years and you can see that in June 2019, there was a paper published describing DHX16 disease-causing variants. And then this patient, again, received whole exome sequencing close to a year in March 2020 with no diagnosis that was found. And then in late 2020, when our providers, kind of nominated this patient for our study, we looked at the data, we found this de novo DHX16 variant and diagnosed, this patient with DHX16 associated neuromuscular disease and auditory anomalies. So it's really, at least 2 cases from our study that we have seen this missed opportunity for an early diagnosis, right? So you would think, does this matter, right? You could diagnose it 1 year earlier, but if the data was there, really, we want to be sure that we capture all this data that's already out there, that's been published, so that we don't miss them. Then one other case that I have as an example is, again, as an ultra-rare case, was a variant in this gene called IRF2BPL that was recognized since 2018 to be associated with a neurodevelopmental disorder. But this gene is complicated. It's really only single exon, but there's a stretch of 50 alanines and 25 glutamines in the region, which is very unusual. And you could have normal variation in the number of glutamines, but not the alanine. But that compounded the analysis to a very large extent. So our patient was 20-month-old male with global developmental delay. So this kid is pretty young, right? So not like the other kids who have remained undiagnosed for many years. This kid is really less than 2 years old at that point. But again, was undiagnosed by whole exome sequencing. So we kind of took over the case when our providers decided that there has been something going on. Like, can you please look at the data? So we enrolled him in genome, and we reanalyzed the exome data, and just to see, can we find something that was previously missed? So in this case, this was more of a technical issue, because on a whole exome data set, you have to do enrichment for sequencing. And because this region is very GC rich, there's so many alanines and polyglutamines encoded by a lot of G's and C's, the coverage for whole exome was pretty low. But you could actually see the variant if you really were looking. So there is a 32 base pair deletion in the alanine region that was deleted. But because the whole region is so difficult to map, and if you look at this on IGV, you would very quickly, easily discount, this is just junk, this is not good data, I'm just going to move on because this is not a real variant. So that's what we think happened, in the reference lab as well. Is, some of these things are missed because of the technical issues with whole exome sequencing. Right, so kind of a quick look back at what we have kind of found, just from this little study at Lurie, was that obviously there are different reasons why a whole exome can fail to capture a diagnosis. One is, the main key one is, for the purpose of this session today, is really, missing the focus on the appropriate genes of interest, and essentially really missing key publications that describe the novel gene-disease association. Missing, or it could be due to the fact that, if the providers miss that some phenotype that could be relevant for a patient. When we do whole exome, whole genome, you're really looking at the phenotype and then coming up with a gene list of focus for analysis. So if the providers had missed that phenotyping step, you could fail to pull up genes that are relevant for the analysis. So that's one thing that we're working on to kind of improve. And again, it could be, like I said, it could be technical challenges. It could be because exome is just unable to really interrogate those genomic regions that you could be missing variants in that gene. So pipeline issues are going to be common to both exome and genome analyses. So really what I really want to focus on today is really addressing that key point of how do you ensure that we don't miss publications that describe that novel gene-disease association, because really that is key to kind of solving this rare disease cases. So really ensuring review of key publications is very time sensitive. So like I've described, at Lurie, we pretty much built up the genomics lab sort of from scratch in the beginning, where we had to kind of really look at tools that would help us get to the point of getting a diagnosis for our patients as soon as we can. So we have a couple different tools that we have in-house. In terms of our clinical testing menu, we have NGS testing, we have microarray testing. And so you have sequence variants, you have CNVs, how do you kind of put all of them together? But really the tools for examining those genetic variants we have in-house, but then how do you do the interpretation? How do you make sure that our staff members, our analysts, have the tools that let them get to assessing the case, every single case in the most efficient manner, right? Because as we know, if they take if it's an inefficient process, that's when people start putting in more time in areas that are not needed, and they may actually miss the important variants that could be disease causing. So we had all this data that actually kind of funnels into this decision framework that we kind of examine. We look at, obviously, when we examine variants that are either CNVs or genetic variants from NGS testing, we look at population frequencies because that determine whether those variants are found in the general population. We look at the variant effect. We want to be able to look at classification data from other testing labs. So we look at ClinGen, ClinVar. And then literature support is really one of the key things we look at for some of the really rare conditions that we are examining, and then potential inheritance pattern within the family, right? So this really is sort of the 5 key things that are examined under the ACMG criteria, loosely said, to inform you whether a variant is disease-causing or not. So kind of really looking at literature support, right? As I mentioned, this is one of the key things that we look at to determine is a variant disease-causing or not. So for really rare genetic conditions, I can't say for all the other panels that we do, if it's epilepsy, panel that we are performing, most of those genes have very well-described association with the disease that you're testing for. But if you're looking at whole genome, whole exome, where you don't really have a panel-based, phenotype-based kind of focus yet, these rare genetic conditions, you might really need to make that diagnosis based on a single publication, as like the previous cases have kind of shown. So really the failure to detect those relevant publications can really be a cause for missing diagnosis. So how do we prevent ourselves from missing those papers, right? Kind of looking at the other reference labs and then kind of seeing what happened. Internally, we were trying to make sure that, all right, this doesn't happen to us, right? We want to make sure we have a very timely review of every paper that is out there on a very specific rare variant. So we kind of examine how we can do that. So we reviewed our protocol for assessing gene variant literature for clinical interpretation. So I'm going to describe to you some of the things that we do when we are trying to tackle that part of a literature review for a specific variant. So as a clinical diagnostic lab, one very key tool that a lot of labs kind of have used over time is HGMD. So HGMD is an annotation that's brought in for each sequence variant. We bring it in during the annotation pipeline part, which means that when we do a sequencing assay, we have a variant. We want to be able to answer the question, has this variant been seen before by HGMD? Is there a paper that has described this variant? So that is one key part of our pipeline. And then really the next thing is looking at ClinVar data, and then we do search engine, right? So we would do PubMed, we would Google it. And then we also build in this process where we would do a Genomina Mastermind. And I think over the last 2 years, I would say, we've been using Genome Mastermind. I have a few cases that kind of showcase how it has made a difference. So really, and then the last thing is really gathering unpublished data. So if you don't have literature support that's already published, the only thing you can do is private communication. If you know of a person who's an expert in a disease area, reaching out to them, or a gene, reaching out to them and saying that, do you know anything about this variant? Or we have this, NCBI supported tool called Gene Matcher. We put it into Gene Matcher, and then we see if it comes up with a hit. So that's really what you can do to examine literature review, a search for specific genes or variants. So what we did at Lurie that we adopted in 2021 was to establish a more efficient process with a high yield. So like I mentioned, we have HGMD that's built in our pipeline. So we annotate every single variant that we see with annotations that indicate did we find them in HGMD. So we have both a BI pipeline annotation and also a live search. So we also go to HGMD, we make sure that variant is not in HGMD. And then because of our integrations with Fabric and Mastermind, we then could also, at the same time, do a parallel search to make sure that HGMD says it's nothing, but is it truly nothing? So we kind of do this kind of a backup system, right? So to make it redundant such that we don't miss anything that could have been outside of HGMD. And then the last thing is, if, like I said, if it's negative again, then really we would maybe potentially submit the variant to Gene Matcher if it's in a rare gene or disease or variant. So I have like 2 cases that kind of would illustrate how we think this protocol has sort of made a difference in our capabilities to assess these cases. So my case number 1 was to look at this search capabilities for copy number variants, because like I said, we do perform copy number variant analysis by our genomic microarray. And then the case 2 was a kind of a very good example of how, like very timely search for publications can truly make a difference. So my first case is really looking at detection of CNVs. So this is one case that we had done on our chromosomal microarray. It was a 4-year-old male with global developmental delays, and our array CGH that time detected a 3 megabase loss at 18q12.2. So we looked at it initially was, it's DGV. So if you can examine DGV, we have a DGV track down here. So essentially this is like normal population data. There's not quite an overlap. You don't see anything that is quite as big. And then the next thing we can do is we do a literature search, right? So we go to HGMD and we examine the spectrum of disease-causing variants. So this deletion affects this gene, CELF4. So when we first look at it in HGMD, we have a case discussion every Thursday morning, and then we get together, our clinical geneticists, our lab directors, our GCs, analysts, and we do the interpretation for these CNVs that we see. So at first look, we were like, this is pretty weak, right? This is only disease-causing questionable, and then some people actually think, well, maybe we shouldn't even report this. This is like, there's no strong disease association for this gene, at least by HGMD standards. It's just not strong enough. And from a genomic microarray standard, we have to assess phenotype and determine if this is something that we need to report. And we were in between, I guess, on a scale of calling this a lightly benign VUS at the first assessment, right? So that time, we had Mastermind Genomina. I was like, all right, just put it in Mastermind, just make sure that we're not missing anything. So we put in, del CELF4 just as a last resort, right? Are we missing anything? So we saw that in Mastermind, it pulled out a couple more papers that were not previously described in HGMD or actually put in the wrong section. So there's a paper describing CELF4 that gross deletions of this gene could be associated with disease. But if you look at HGMD or where that paper was placed, it was called as a translocation, not as a growth deletion. And that is a problem for us because when we examine mutation spectrum in HGMD, if we don't see a growth deletion being described as disease-causing, we kind of move on. So that was the reason why we were leaning towards, well, maybe this is nothing. But if you look at the additional papers that come out from this Mastermind search, you would see, and we start off like, kind of go through this process, right? Is this a good paper? Is it published in a reputable journal? What is the work that was done? How big was the study? Do we actually trust what was presented, right? Because this is a common variation. Sometimes we have some issues where there are variants that are very common that are recurrently described, but they're not truly associated with disease. So we kind of have to go through this process where we assess, are these papers solid? Are they really supporting the fact that this gene deletion could be disease-causing? So when we examine that, we have a couple of papers that we found, even that was published in 2017 that clearly starting to emerge that this gene deletion could be disease-causing, but somehow this paper was just not in his GMD, right? So this was some key thing that it was not a factor of time. Like we believe for HGMD is there's every quarter updates that happen, but it is not a factor of time because if it didn't make it in for a paper that is from 2017, it's not going to make it in the later stage unless, I guess, we kind of give them feedback. So this was kind of a skewing. So when we initially first started looking at this variant, from what we originally thought with our usual kind of protocol, we thought VUS, largely benign, maybe nothing. Somebody was like, maybe we shouldn't even report it. But then looking at the Mastermind data, we decided, well, I think this needs to be reported. This has to be at least be a VUS because we just don't have enough papers. I think it was up for debate because we were thinking that if this was a VUS, we could test parents, and if it turns out to be de novo, we can upgrade it. So we went very conservatively, reporting this as a VUS, and then very, very strongly recommended parental testing and said, well, this is very suspicious VUS, please send the parents. And then we found that it was de novo. So this was completely not found in the parents, so this is only in the proband, and proband has a phenotype that, although it's very non-specific, it's consistent with a defect in this CELF4 gene. So overall, you can see that this kind of skewed our assessment as how we kind of go through this process. But overall, it really alerted us to the fact that, again, with our new modified way of doing lit search, that this is really not missing those variants that actually truly could turn out to be disease-causing. And I have a second case that kind of talked about just kind of how sometimes the time incidence of how some cases come in for testing can really mess you up. And it really can make a big difference of whether you miss something or whether you actually capture the right diagnosis. So case number 2, this is a 2-year-old female with Evans syndrome, anemia, thrombocytopenia. So nothing really very eye-catching, right? Because we get a lot of patients with Evans syndrome and we never find anything with the immunodeficiency panel that we do. Our PID panel, our primary immunodeficiency panel, is 330 genes, so it's pretty big. And we end up reporting usually a good amount of VUSs, and they get lost because if we have 19 VUSs, this is one of the VUSs in the list. Usually they just don't really get the clinical attention. So we were looking at this case. There were 19 VUSs, and then there was one variant that was kind of interesting called CTLA4. This gene was interesting, and this variant's not been seen in ClinVar. There's really nothing much that we can say about it. It was classified as a VUS. So this was going to end up as a VUS, one of 19 in the report. But one thing that caught our attention was, well, there's a splicing prediction. So it's the last base of the intron exon boundary. Maybe we should look at this a little bit more. So it does seem to disrupt the canonical splice site. So we wanted to be able to examine this. So nothing was pulling from HGMD because we didn't see our BI annotation pulling anything. So we threw this variant in Mastermind, did some quick search, and there was a paper that kind of popped up and that was published. And that was published, I believe, in a time frame that was really close to the point where we did the testing. probably, like I would say, like it was a month before we did the testing. I think it was a month before we did the testing, but our BI pipelines get updated every 6 months. So this paper didn't make it into our BI pipeline yet, and it wasn't even in HGMD at the moment anyway, but it was in Mastermind, right? So this one paper was one of the key papers, and then reviewing HGMD entries. Finally, as you kind of follow along, finally it made it into HGMD, but it made it into HGMD Professional, that you could see it there, but not in our pipeline, because our pipeline hasn't validated this version and put it in our pipeline yet. So we almost missed this paper because of how the timeline kind of played out. So I kind of describe it this way. So 2019 was when this paper was published. And then in June 2020, there was a JCI paper that I think was like really key to really showing that this variant is disease-causing. The patient arrived December 2021 for testing at Lurie. Our BI pipeline was using 2021 version 3, quarter 3 HGMD updates. But then 2021 version 4 got released later. So our reporting happened sort of somewhere here. So we almost couldn't see that variant if we didn't actually, spend more time searching and throwing it into Mastermind. It might have, been reported as VUS. So this is really, again, this one paper, like I said, for rare disease, that one paper is going to make a difference. Is it a diagnosis or not? But this variant, it is ultimately, when we assessed this paper, reported as pathogenic. So if this publication was missed, then we would have classified it as a VUS, because there is really a novel variant, has not been described before. If this was a case done in whole exome sequencing and it was interpreted as a VUS, it may never even have made it into the report, because whole exome sequencings don't report every single VUS that they see, right? So you can see how these things kind of could compound and cause the misdiagnosis. So I want to summarize what I've kind of showcased today in terms of our work at Lurie. So really there are many ways to fail at whole genome, whole exome sequencing analysis, many ways. But we need to do better at minimizing them. And I think one easy thing for us to do is always to make sure, I think one easy thing to tackle, there's a couple of things that we are tackling at Lurie right now, things that are looking at phenotype, whether we can capture phenotype more effectively, whether we can address the technical challenges of, uncovered genomic regions. But then this literature search thing is like a no-brainer, right? I mean, if you should do better at searching, you should be able to find those papers, and then some of these cases actually could get solved even without doing other things. So late review is really a critical process, right? If you have a rare disease diagnosis, you're really hinging on that 1 or 2 papers that are out there. And if you don't find them, you're not going to be able to make that diagnosis for those patients. So tools to perform those lit search is really necessary, and especially for CNVs. I think one thing we were lacking for a long time was really a tool to search for CNVs, because it's not in ClinVar, right? ClinVar doesn't really do a good job of categorizing those CNVs. So in our experience, we really do think that using a real-time search really benefited us in some of those cases that we have seen. So we continue to use this for our rare disease diagnosis, and like I mentioned, we have become a UDN clinical site. So moving forward, I think we'll be really using some of these tools to really make sure that we don't have we maximize our capabilities to diagnose these cases. So with that, I want to acknowledge, we have our Molecular Diagnostics lab at Lurie, our bioinformatics team, our rare consortium that's made up of our genetics team, our lab, and the research people, and ACGEM, our division of genetics, obviously the patients and families who participated in our study. And I want to thank Genomenon for Mastermind for inviting me to kind of do this sharing session. I'm happy to take questions.
Yes. Do you think 6 months is the right cadence for updating pipelines like that, or what would you want to see?
You mean the lab internal pipeline for analysis. I think 6 months is the minimum. I think our lab has kind of gone on to trying to do it every quarter, but I think 6 months. 6 months is something that's because in the diagnostic lab we validate a pipeline. Yep. Is a lot of work. Yep. So it is very. I think we've done it such a way that the larger pipeline validations are pretty extensive. We're not going to touch that, but our databases that we kind of tap into, those are considered minor updates, and we try to have our BI team get on them every quarter, so that it goes in at least for database annotations that need to make it into the pipeline, and we try to do it every quarter. Every time a release comes out, we try to have them do it. Yeah. Ideally, I think would be every month if somebody can do it, but it's not possible. Yes.
Do you think there is also an issue of these publications, the authors not uploading to ClinVar on time? Because you would have seen it, right? If there was a variant, for example, the CTLA4, you could have seen it on ClinVar if they had reported a publication.
Yeah. So good point. So it really depends on where those studies came from. So if it was from a clinical diagnostic lab, I think ultimately they probably would submit to ClinVar and make it in. But I feel like a lot of people, they publish papers first, and then the ClinVar submission, even for us, we do a bulk upload every 6 months, every year. I mean, maybe once a year, and then we collect all our variants and then we dump it in ClinVar. So we're not like finding a variant and then pushing it into ClinVar, because that's not. It is a good thing to do, but it's not one of the priorities that I think a lot of labs invest in. They would do it once a year, they would do it every 6 months, but it's sort of like an afterthought kind of thing. So I think for this CTLA publication, I want to say it wasn't really from a clinical group, but they found it from a study. And if they were not a clinical diagnostic lab, I don't even think they always think about ClinVar, because I think ClinVar is a very diagnostic lab kind of sharing thing that we try to do. Yes.
One thing that interests me is the gene-disease relationship portion of this. And for these ultra-rare diseases, if there's no publications out there, it's really hard to classify it as pathogenic or likely pathogenic. What's your threshold when you're looking at some of these ultra-rare to say that one publication is enough that we could call this instead of like a VUS or a GUS, a gene of uncertain significance? What is your threshold to be able to say, we can call this pathogenic?
Yes. Yeah. That's a really good question, because we go through that every Thursday, right? And like I've shown, the CELF4 variant, the deletion, we had a paper. We at least we saw the paper and saw that it was kind of emerging. One good bar that we have is the ClinGen the ClinGen curation. If ClinGen has curated it and said it was haploinsufficient, then I think that is like the bar has cleared. Then we will make the jump. But a lot of times for this rare disease, like I said, it hasn't even been curated yet, right? So it doesn't really exist in ClinVar's literature yet. It's just uncurated. So ClinGen, sorry. So we really read the paper, which is why it takes some humans to do that. We really pull apart our paper and look at how many people they had done and shown, and what the phenotype is. The really hard ones are the ones that have a very non-specific phenotype, like the CELF4, right? Which is why we put it as a VUS, because global developmental delay. Like it's like every neurodevelopmental disorder is that, right? So it's very non-specific. So those we tend to be more conservative and say, I'm not sure what we put it. We put it as a VUS. But there are things like, for example, this would be a good example, like the case about this case, right? For example, this DHX16. So our patient here is the 7th patient described with the condition. And so the previous paper, the other 6 patients that were described, right? Do I really believe that this gene was the cause? And really diagnosing this patient. But for this case, I think it really depends on the gene. If the phenotype was very specific, and for this gene, it has three things that come together: neuromuscular, eye, and hearing anomalies, right? So they're very distinct, right? So if we see that the same three things being hit, being abnormal, that is very specific, then I'll be okay saying, well, I think this patient has the same thing, has all these things, has eye anomalies, exactly fits this. So it really comes back to, I think, phenotype. But that, again, goes back to how well those people have phenotyped their patients when they publish it. So it all hinges on the quality of the publication. So, and then gene matcher is also a good kind of, I would say this other case about this ChRNA3, right? So we had that one paper, 2019, that was published. It wasn't strong enough because that paper was described by a group who was very focused on the kidney anomalies, but didn't really describe all the other hypotension, all the other features that are there because they're kidney specialists, right? So they published a paper that was very kind of focused on characterizing kidney function. So if I only saw the 2019 paper, at that point, I don't think we'll be able to do it, but it's really through gene matcher. So we put in gene matcher. There was a different group of people who had patients with exactly the same variant as my patient, who's not the same patient, different race, but had the same phenotype. You know, like bowel dysmotility. So it's really, again, based on the phenotype. And then we kind of make that jump and say, yeah, this has to be it. And then later they published that paper. Because I think if their paper was out, we would have made the diagnosis with no problems. But without that, I think it's hard. Our GCs have a sort of a criteria that they internally would say they need at least 3 papers. But I'm like, that's not always 3 papers, right?
That's hard.
If you have 4 bad papers, do you count it? Or do you have like 1 great paper? So it's a discussion. I think that's why we kind of discuss among ourselves and go with what we think is the most appropriate in terms of judgment, our professional judgment. Thank you.